Hello, everyone. My name is Ahmed. I'm a third-year pathology resident, and today I'm going to be talking about acute myeloid leukemia, myelodysplasia-related. This is a myeloid neoplasm that has specific cytogenetic or molecular abnormalities associated with myelodysplastic neoplasia (MDS), arising either de novo or after a non-diagnosis of myelodysplastic neoplasm MDS or after a non-diagnosis of MDS MPN. It's a very common leukemia that accounts for about 24 to 35% of all cases of acute myeloid leukemia. It arises de novo or from previous MDS or MDS MPN. Most patients present with pancytopenia and symptoms related to pancytopenia. Morphologically, you need to see increased blasts, and multilineage dysplasia may be seen. However, it's not essential to make this diagnosis anymore. Now, let me show you this case of a 52-year-old patient who presented with progressive shortness of breath and was found to have circulating blasts in the peripheral blood smear. So let's go around and have a look. And then, as you can see, there are empty spaces between these red blood cells, so the patient is anemic. I don't see a lot of white blood cells, so the patient is leukopenic. Let's go around and try to see if we do see any blasts going around. Going around. Let's go here. This cell here is a blast. It's intermediate to large in size with a large nucleus, prominent nucleolus here, and it has moderate amount of cytoplasm with some fine granules. Here in this field, I see 1, 2, 3 nucleated red blood cells. Let me go high power, show the morphology. This one here is a nucleated red blood cell. As you can see, the color of the cytoplasm is very similar to the color of the mature red blood cell, and we do have this clumped nucleus here. Let's go around to see if we can see more blasts. This cell here in the center of the field is a blast. It has large nucleus, high NC ratio, prominent nucleoli, and it has scant amount of cytoplasm with some fine granules. These are the granules here. So this one is a blast. Let's keep looking. And sometimes in these patients with leukopenia, I go on low power. That would give me a better visualization of what's happening. Let's go high power on this cell here. This cell here is a blast as well, and it has these granules, pink granules in the cytoplasm. So far, I do see rare circulating blasts. It might not be too many blasts, but when you consider the fact that the patient is leukopenic, and then with this leukopenia, we do see some circulating blasts, then the blast percentage would probably be high in this patient. This is a blast as well. Since we're talking about acute myeloid leukemia, myelodysplasia related, I'm hunting for the neutrophils, trying to see if there is an element of neutrophilic dysplasia. This cell here in the middle, in the center of the field, is a blast, and you can notice the big size of this cell compared to the other surrounding red blood cells. I do see many nucleated red blood cells, and I do see very few neutrophils, not a lot of neutrophils. This one here looks morphologically normal. However, remember that currently to make a diagnosis of acute myeloid leukemia myelodysplasia related, you don't necessarily need to see multi-lineage dysplasia. So yeah, I do see rare neutrophils, and these neutrophils do not show apparent dysplasia. Now let's have a look at the bone marrow aspirate smear. As you can see, it's very cellular and spiculated. Let's go high power here. This cell here is a megakaryocyte, however, it's monolobated. So this is a dysplastic megakaryocyte. This one here, this is our dysplastic megakaryocyte. This one here in the center of the field is a micromegakaryocyte. And micromegakaryocyte is a megakaryocyte with the same size as surrounding promyelocytes. And for comparison, this is a promyelocyte. So this is more or less the same size, maybe slightly larger. But this is a dysplastic megakaryocyte as well. Here, this one. Let's go around to see if there is more megakaryocytic dysplasia. This one here is a monolibated megakaryocyte. This one here is another monolibated megakaryocyte. So we do have an element of megakaryocytic dysplasia for sure. This one here is a micromegakaryocyte. Okay, now let's have a look at the erythroid lineage. Let's go here. I'm looking for erythroid dysplasia, meaning I'm looking for binucleation. I'm looking for nuclear budding. I'm looking for irregular nuclear contours. I'm looking for nuclear to cytoplasmic maturation asynchrony. These are the things that I'm generally looking for. And then here, as you can see, we do have some nuclear budding. We have this erythroid precursor. This is the cytoplasm of the erythroid precursor, and this is a nucleus undergoing nuclear budding. So this is a sign of erythroid dysplasia. This one here is an erythroid precursor with irregular nuclear contours. So this is another dysplastic erythroid precursor. This one here is an erythroid precursor with binucleation. As you can see, we do have two separate nuclei. And this cell here is a mast cell. So overall, I do see an element of erythroid dysplasia. I've been scanning just for a little bit and I saw a couple of dysplastic erythroid precursors. Here I might see another one here. Binucleated erythroid precursor. So far as I've seen megakaryocytic dysplasia as well as erythroid dysplasia. However, I cannot emphasize enough that the presence of multilinear dysplasia may be present, but it's not necessary to make a diagnosis of acute myeloid leukemia, myelodysplasia related. Now, this is Prussian blue stain. And this in blue-green here is iron. So we do have increased iron stores in the bone marrow of this patient. I'm trying to see if there's any ring sideroblasts. You have to go away from these areas that has these spicules and go to the surrounding areas. So as you can see here, we do have these granules, green granules surrounding this erythroid cell here and this one here as well. So these are, and this one here as well. So we do have ring sideroblasts. Let's look now at the bone marrow core biopsy. And as you can see here, this bone marrow is markedly hypercellular. I would estimate the percentage for such a case for about 80%. It's at least 80%. So it's markedly hypercellular. Let's go around to see what's happening. Let me add some oil. Focusing on the screen now. And here what I'm seeing is I do see some cells with open chromatin, prominent nucleoli. Some of them have irregular nuclear contours. These are probably immature cells. We're going to look at the CD34 immunohistochemical stain to see if these are blasts. And I do see some erythroid precursors here and there. I do see some scattered megakaryocytes. Like this one here is a megakaryocyte. This one here is a megakaryocyte. And this one here is very small and tiny. It's a micromegakaryocyte, and it has this hyperchromatic nucleus, and I don't see any elevation. So we do see an evidence of megakaryocytic dysplasia in the bone marrow core biopsy for this patient as well. Now let me show you CD34 immunohistochemical stain. And as you can see here, all these cells with this surrounding membranous brown pigment are counted as blasts. C34 highlights hematopoietic stem cells. It's pretty variable. We do have some areas here that are heavily stained, and we do have other areas here that are less stained. And you have to be careful because CD34 highlights vessels as well. So for example, this is a vessel here, this is a vessel, and this is a vessel here as well. And we ended up estimating the percentage of C34 in this case as 40%. Now, let me take you back to our presentation. So we said morphologically you want to see increased blasts, and in this case we saw circulating blasts in the peripheral blood. The bone marrow showed increased blasts as well, both in the aspirate smear as well as the core biopsy, and we did CD34 immunohistochemical stain that highlighted these blasts. As for the immunophenotype, blasts often express CD34, CD117, CD13, HLA-DR, and MPO, usually at aberrantly high levels or low levels. Now for our patient, let me show you the flow cytometric findings that we saw in this case. As you can see here, we do have our red to brown dim CD45 population. This population here, I would describe it as CD34 dim. Some people would describe it as partial, since some of the blasts are negative and some of the blasts are positive. T-cell lymphoid markers, including CD2, CD3, CD5, and CD7 are negative. CD19 and CD56 are negative as well. Here, CD19 and CD20 and CD10 are negative, and CD38 is dim. This population is positive for myeloid markers, including CD13, CD33, and CD117. HLA-DR is dim, and CD123 is positive in over 70% of the cells, and always try to give a percentage because there's targeted therapy against CD123. And here, CD123 is positive in about 74% of the cells, or 77% of the cells. Here we're looking at our monocytic tube. The blast population is negative for CD11b, CD14, CD16, and it's dim for CD64. So we don't have expression of monocytic markers by flow cytometry. And lastly here, our blast population is dim for MPO, and it's negative for TDT and CD79A. So this is the general immunophenotype for cases of acute myeloid leukemia, myelodysplasia-related. As for the molecular findings, we do have defining somatic mutations. These somatic mutations involve 8 genes that can be categorized as chromatin modifiers, including ASXL1, BCOR, and EZH2. The second category is the splicing complex, including SF3B1, SRSF2, U2AF1, and ZRSR2. And lastly, the cohesion complex STAG2. We do also have defining cytogenetic abnormalities. These include complex karyotype, which means at least 3 abnormalities, 5q deletion or loss of 5q due to unbalanced translocation, monosomy 7 or 7q deletion or loss of 7q due to unbalanced translocation, 11q deletion, 12p deletion or loss of 12p due to unbalanced translocation, monosomy 13 or 13q deletion, 17p deletion or loss of 17p due to unbalanced translocation, and isochrome 17q, as well as this one. The essential criteria to make a diagnosis, you need to identify at least 20% blasts in blood or bone marrow. In addition to that, you need the presence of at least one of the following 2 criteria. The first criteria is a history of MDS or MDS-MPN. And the second criteria is 1 or more cytogenetic or molecular abnormality that define AML myelodysplasia-related. And these are the defining somatic mutations, and these are the defining cytogenetic abnormalities. So you need at least one of these 2 criteria. Also, you need absence of the following: a history of exposure to cytotoxic therapy, a history of myeloproliferative neoplasm, criteria for AML with defining genetic abnormalities, and criteria for myeloid neoplasms associated with germline predisposition. Also, note that the diagnosis of acute erythroid leukemia supersedes AML myelodysplasia-related in view of its distinct clinical pathological features. The prognosis for this leukemia is generally poor. TP53 is frequently mutated in acute myeloid leukemia myelodysplasia-related and is strongly associated with a complex karyotype, which could be a potential independent poor prognostic factor. Some cases in patients with prior MDS and less than 30% bone marrow blasts can be called oligoblastic AML. Myelodysplasia-related, these cases may behave in a manner more similar to MDS than other acute myeloid leukemia types and may be managed accordingly. This is supported by the fact that patients with oligoblastic AML myelodysplasia-related have shown response to therapeutic trials for MDS. Their overall and leukemia-free survival times are similar to those of patients classified as having MDS with increased blasts. And the molecular and cytogenetic features of these two patient groups are very similar. This is the end of this video, and see you next time.